Bismillahirrahmanirrahim. Assalamu alaikum. Thank you very much, organizers, for having me here today. It is indeed an honor for me to be present here among the luminaries of rheumatology. So I've been given the daunting task of delivering a talk on auto-inflammatory disorders. It is a very extensive topic, as we all know, and I'm sure I wouldn't be able to finish it in 30 minutes' time. ये बिल्कुल उसी तरह है कि दरिया को कूज़े में बंद करने वाली बात है, but I'll try to do my best here. So first things first, let's start with the definition of systemic auto-inflammatory diseases, abbreviated as SIDS. So basically, this is a group of diseases characterized by periodic or chronic inflammation secondary to defects in the innate immune system. So they have got nothing to do with the adaptive immune system. That is why we do not find any antibody formation in these disorders, and nor is there any activation of T cells. So far, mutations in 20 genes leading to more than 60 distinct auto-inflammatory syndromes have been described. And since these are genetic disorders, they generally have an early age of onset, ranging from first few hours to the first decade of life. Their onset in adulthood is quite rare. And also, since different kind of proteins are involved, the clinical spectrum of these disorders is also quite variable. Now, before I go into the details of individual clinical syndromes, let us revise our knowledge of innate immunity. Let's revise the different pathways that actually mediate the inflammation caused by the innate immunity. So basically, at the center of this whole process is a multi-protein structure which we refer to as inflammasome. There are different kinds of inflammasome in our body. Two of these are shown in this cartoon. One is this NLRP3 inflammasome and another is pyrin inflammasome. So this NLRP3 inflammasome is quite sensitive to cellular damage secondary to infections, toxins, or metabolic disturbances. So once this gets activated, this in turn activates the caspase-1 enzyme system, which in turn cleaves the inactive forms of interleukin-1 and interleukin-18 into their active forms. And we know that interleukin-1 and interleukin-18 are both very potent mediators of inflammation. Second here is the pyrin inflammasome, and this is very sensitive to cytoskeleton problems. So whenever there is disruption in the cell membrane, this inflammasome gets activated, and in turn, it leads to activation of caspase-1 system, and from there is activation of interleukin-1 and interleukin-18, and hence there is inflammation. Thirdly, we see another, this pointer isn't working very well. So thirdly, we see another pathway, this nuclear factor kappa B pathway shown at the end, this protein over here. This is also a multi-protein structure. And its function is to induce transduction of DNA inside the nucleus and formation of cytokines. So once this pathway is activated, different other cytokines are produced, as well as transcription of DNA takes place, and the end result is inflammation in the body. And then we also have certain other pathways like the TNF pathway that we see over here in the left-hand side. And then there's also interferon gamma pathway. So under the normal circumstances, there are also present inhibitory molecules inside the cell that act as a switch-off mechanism, and they ensure that the inflammation is carried on only till the time that it is needed. However, in auto-inflammatory diseases, because of genetic mutations, there is either complete absence of these inhibitory molecules, or if at all they are present, they are mutant. So the result is an unchecked and dysregulated inflammation that can pose serious damage to the tissues. So with this background in our minds, let us now move into different categories of autoinflammatory diseases. Now this is just a breather. After such a busy slide, I thought we all deserved a breather. So all who fever are not infectious, and this is basically the theme of my talk. Everybody who has fever does not necessarily mean that they are infectious. There are many other causes of fever as well. Right, so when should we suspect somebody is having SEDS? So the first and the foremost point is recurrent flares of systemic inflammation in the form of fever, rashes, serositis, articular involvement, lymphadenopathy. And all these features must not be attributable to any infectious cause or any other malignant process going on in the body. There should be no plausible explanation for these features. Second clue is, we get the second clue through persistently elevated CRP and ESR, and if available, systemic amyloid A protein and S100 protein can also help us. And then some patients would become absolutely symptom-free in between the flares without taking any medication or without any other intervention. So this this symptom-free period is another clue towards the diagnosis of SEDS. And then most often, there is also the presence of an identifiable trigger such as stress or sleep deprivation, or the child might have had vaccinations or have had some viral infection that has sort of triggered the inflammation in the body. So once we suspect SEDS in a patient, there are certain clinical characteristics that can guide us towards the diagnosis of a specific SED. So first and the foremost is the ethnicity of the patient. So we all know that familiar Mediterranean fever is most common in patients who have Armenian ancestry or who are Turks or Arabs. Similarly, another periodic fever by the name of TRAPS is more common in Western and Northern European children. If we talk about DADA2, this is more common in patients who are from Middle East or from South Asia. Next, inheritance pattern can also help us. Some of these diseases are inherited in an autosomal recessive fashion and some in autosomal dominant fashion. So if a patient has a positive family history of the symptoms in any of the siblings or in the parents, then we should be thinking about autosomal dominant diseases rather than going for autosomal recessive disorders. Age of onset is also very important. Some of these diseases are manifested during the initial first few weeks of life. The best example is SINCA or NOMID or DIRA. And sometimes the age of onset is after the 5 years of age, but less than 10 years of age. So that can also guide us towards a particular diagnosis. Then pattern and length of episodes is also important, as we shall see subsequently. And lastly, there are certain specific symptoms associated with each of these disorders that can help us in making the right diagnosis. So if an infant presents with strokes, we can think of DADA2. If a patient has fever along with very prominent eye symptoms like periorbital puffiness or conjunctivitis, then we should be thinking about TRAPS. Then there are certain patients who present with sensory neural deafness as well. So in those cases, we can think of SINCA, we can think of Muckle-Wells disease, etc. Lastly, type of rash that they present with is also very important. Some of these diseases have urticarial rashes, as we shall see, and some of them have non-urticarial rashes. There can be erysipelas-like rashes, there can be monocytic fasciitis, and with correct identification of the rash, we can move in the right direction. So like I said, there are many ways of classifying these autoinflammatory syndromes. We can divide them into autosomal dominant and autosomal recessive categories. Then we can also divide them into monogenic and polygenic groups depending on the number of genes that are involved. So if we talk about monogenic disorders, we have a couple of famous diseases here. If we talk about polygenic disorders, then again, there's a huge list. These are only some of the diseases that I've mentioned. Overall, we have more than 60 disorders. Just keep that in mind. And lastly, we can also classify them according to their clinical presentation. And this is what I'll be discussing today in my talk. So broadly speaking, we can divide them into 5 main groups. Number 1 is the periodic fevers. Then we have NLRPs, related diseases. NLRPs, if you remember from the previous cartoon, this is the inflammasome, granulomatous disorders, pyogenic disorders, and then we have a group of miscellaneous other diseases having diverse kind of pathophysiology. So talking about the periodic recurrent fevers, these are called periodic because the inflammation is cyclical. There is a definitive pattern of manifestation of these symptoms. The symptoms last for a specific period of time, and then in between the attacks, there is a specific duration in which they are totally symptom-free. So in this group, we have familiar Mediterranean fever, we have mevalonate kinase deficiency, and we have TNF receptor-associated periodic syndrome, abbreviated as TRAPS. And recently, another syndrome has been included in the group by the name of Bafapa syndrome. I'll be talking about that later in my talk. Although there is no genetic abnormality that can account for Bafapa syndrome, but still, since it shows a periodicity, it has been included in the periodic fevers group. So there are certain clues that can point towards the presence of a periodic fever. First and foremost, the periodicity of the symptoms, as I've discussed earlier. Then a positive family history is often present. They usually tend to occur in the initial years of life. And then there are certain characteristic accompanying symptoms like rash, abdominal pain, joint pain, mouth sores, and chest symptoms. And all of them always present with elevated inflammatory markers. So if we talk about familiar Mediterranean fever, usually it occurs before 5 years of age. Duration of symptoms is up to 72 hours only. Usually it's 24 to 48 hours. And after that, even if you don't give any treatment to the patient, the symptoms tend to settle down on their own. Attacks, this disease actually also involves the joints. And usually there's a monoarticular arthritis that we see involving large joints of the body, usually hip, knees, ankles, and wrist joints are involved. And the most dreaded complication of this disease is the development of amyloidosis, which is seen in up to 35% of the patients. And this is the highest incidence in any of the autoinflammatory diseases. So the features which are unique to familiar Mediterranean fever are peritonitis. 95% of the patients would present with peritonitis, and this is a key feature. So if a child comes to you with history of fever, which is recurring in a cyclical manner, and it is associated with severe abdominal pain, then you must think of familiar Mediterranean fever. The pain sometimes is so severe that children have been rushed to the OR for laparotomies. And then there is erysipelas-like rash on the limbs in about 30% of the patients. This is also unique to familiar Mediterranean fever. And then incidence of amyloidosis. So if somebody has proteinuria, concomitant proteinuria, then FMF must be thought about. Next, we move on to mevalonate kinase deficiency. Now, this is unique in the manner that the age of onset for MKD is at less than 12 months of age. And the duration of symptoms is 4 to 5 days. First attack is often triggered by the vaccinations. So this is a diagnostic clue. And abdominal symptoms are also very prominent. However, unlike FMF, this is not a peritonitis kind of a presentation. Patients usually have nausea, vomiting, diarrhea, and abdominal pain kind of a presentation. So the clues to diagnosis include age of onset less than 1 year, prominent abdominal symptoms, painful lymphadenopathy, and aphthous stomatitis. Then moving on, we have TRAPS, tumor necrosis factor receptor associated periodic syndromes. And here the duration of attack is much longer than FMF or MKD. The symptoms can last up to 3 weeks. And the distinguishing feature of this syndrome is periorbital edema. And this is not really seen in other periodic syndromes. Other than this, rash, serositis, and myalgias can be present as they are seen in FMF and MKD. And there's often an erythematous patch overlying an area of monocytic fasciitis. So the clues to diagnosis is a longer duration of symptoms lasting up to 3 weeks, prominent eye involvement, and monocytic fasciitis on limbs. Lastly, there is PFAPA syndrome, which is included in this group of periodic fevers. However, it does not have a definitive genetic basis as yet. The usual age of onset is before 5 years of age. Patients get high spikes of fever, which are abrupt in onset and also settle down abruptly. There's a periodicity in the symptoms. The fever tends to occur every 2 to 6 weeks. Along with the fever, there are prominent aphthous lesions in the gingival tissue. And along with that, patients also have enlarged tonsils, cervical lymphadenopathy. So the clues to diagnosis of PFAPA syndrome include periodic fever, recurrent episodes of pharyngitis and adenitis, and this one feature also makes them prone to wrong diagnosis. You know, a lot of them are misdiagnosed as having tonsillitis. They are being treated with recurrent antibiotic courses, and they show lack of response to antibiotics. However, if we put them on steroids, then their symptoms resolve very quickly. And this is a diagnostic clue. And also in PFAPA syndrome, we do not have any systemic features. There are no abdominal features, there are no chest features. So if they are present, then you must be thinking about other periodic fevers. Next, we move on to the second group, which is NLRPs-related diseases, also known as cryopyrin-associated periodic syndromes. And in this group, the three main diseases are FCAS, Muckles-Wells syndrome, and SINCA. And then we also have a newly diagnosed syndrome termed as NLRP12-associated periodic fever, and then there are 1 or 2 more NLRP-associated diseases which are included in this group. So the diagnostic clues here would be an urticarial rash. So I mentioned earlier on that certain periodic autoinflammatory diseases present with urticaria-like symptoms, and this group of diseases is one such example. Cold or stress triggers the episode of inflammation, and patients then present with periodic fever, and also with urticaria-like rashes. Basically, this is a spectrum of clinical features. On one end, we have the mildest form of these diseases in the form of familiar cold autoinflammatory syndrome, in which patients only present with skin symptoms and fever. Somewhere in the middle, we have Muckles-Wells syndrome, in which we also have systemic features. And at the other end of the spectrum, we have SINCA or NOMID, which is basically chronic infantile neonatal cutaneous chronic infantile neurological cutaneous and articular syndrome. This is the most severe form of monogenic autoinflammatory diseases diagnosed so far. It is a triad of rash, arthropathy, and chronic aseptic meningitis. They have specific facies and also show intellectual disability. Sensorineural hearing loss is a prominent feature, so audiograms need to be done. They present with daily fever and other multisystem abnormalities. Lymphadenopathy, hepatosplenomegaly are also a feature. If we talk about arthropathy in SINCA, we see that patients present with persistent joint swelling and pain. There is epiphyseal and metaphyseal overgrowth. We can see here that the patella is showing overgrowth, and contracture formation and limited mobility is also quite common. If we talk about neurological symptoms of SINCA, this MRI brain is from a 12-year-old girl, and you can appreciate that there is very prominent cerebral atrophy, and there is also ventriculomegaly. So these children have chronic aseptic meningitis and present with headaches, vomiting, irritability, seizures, ataxia, poor coordination. Along with that, they also have sensorineural hearing loss. Next, we move on to granulomatous disorders. Here again, we have a couple of diseases, but the most prominent of these is the Bloss syndrome, which is basically a triad of non-caseating granulomatous inflammation that we see in joints, skin, and uveal tract. So these patients present with arthritis, uveitis, and dermatitis. The clues to diagnosis include bilaterally symmetrical polyarthritis with boggy synovitis, but mind you, this can confuse the clinicians and they can make a diagnosis of polyarticular GIA. They also have prominent skin involvement in the form of ichthyosiform rash, which is present in about 90% of the cases. And eye involvement is also quite prominent. They can present with uveitis, cataract, or secondary glaucoma. Next, we have pyogenic disorders in which we have Papa syndrome, we have Majeed syndrome, DIRA, DITRA, and a couple of more. So the hallmark of this group is pyogenic inflammation. Patients present with pus formation, either in the joints or in the bones or in the skin. However, if you culture them, there would be no bacterial organism found. So Papa is basically a syndrome in which we encounter prominent skin lesions. Patients can present with pyogenic gangrenosum. Patients can present with prominent cystic acne, and they can have sterile skin abscesses, especially at injection sites. If we talk about arthritis, arthritis is usually pauciarticular. Recurring inflammatory episodes resemble septic arthritis. However, if we send the synovial fluid for cultures, there would be no bacterial growth. Next, there is Majeed syndrome, and this is said to be a genetic form of chronic recurrent multifocal osteomyelitis. There are certain points that can distinguish between CRMO and Majeed syndrome, and these are genetic defects. In case of Majeed syndrome, there is a definitive genetic defect in the LPIN2 gene. It has an earlier age of onset. It is associated with congenital dyserythropoietic anemia, which is not seen in cases of CRMO, and also skin involvement in the form of Sweet syndrome can be seen in patients of Majeed syndrome. Next, we have DIRA, DITRA, and lastly, the miscellaneous group of autoinflammatory diseases in which DADA2 is very important. Here patients can present with lacunar strokes, livedo reticularis, and pan-like systemic vasculitis. We can have Candle syndrome, then we have Savy syndrome, Hoyle-1 deficiency, related disease, etc., etc. So to conclude my presentation, briefly discussing the treatment of autoinflammatory disorders. First and the foremost thing is to identify them and then to treat, and then to focus our treatment on blocking the primary inflammatory pathway involved in each disease. NSAIDs and glucocorticoids play an important ancillary role. There is a definitive role of colchicine in management of familiar Mediterranean fever. Interleukin-1 blockade is effective in disorders mediated primarily through IL-1 beta, including inflammatories, deficiency of DIRA, and TRAPS. In cases of DADA2, we can use TNF-alpha blockade, and in cases which are mediated through interferon, JAK inhibitors have been found to be very useful. These are the complications that can be encountered in patients of autoinflammatory diseases. This is the last slide, perhaps, and this gives a clinical approach to patients with suspected autoinflammation. So first, you need to suspect autoinflammation, and we have discussed the clues in detail previously. Then you have to recognize the pattern based on the unique characteristics that these diseases carry. Then you can go for genetic testing where available, and lastly, you have to treat them accordingly. Thank you very much for your patient listening.